down, and you cannot generate the PSI you need to really separate this fairly well. So I do recommend using a hybrid knife with a Irby Jet for this procedure. It just makes it a lot quicker and easier, honestly. Moving back down and looking again. Making our way around. Probably going to go up a little higher on this now. As far as difficulty of ESD goes, this can be hard sometimes, harder than a colon ESD, and sometimes easier. Kind of depends on how scarred it is, honestly. But we always tell our colleague Hiro Ihara these are much harder than his procedures, which is quite. Oh, that's a big one. So anytime you guys want to go over to Sai and start the Rose case, you're welcome to. I'm just going to be doing this. It's just a lot of the same. We're just dissecting all the way around. It's such a big outlet. It's probably going to take me another 10 minutes or so. Are we not getting audio on here?
Thank you, Dr. Thompson. Now we are going to call Dr. Girapinho.
That sounds great. Thank you.
Thank you. Dr. Girapinho, now we are going to see your slides.
Hi again from Brigham Room E. So we have our wonderful team here. You met Trent earlier. We do some swab between Dan and Trent. So first off, we're going to start with a case presentation by our bariatric endoscopy fellow.
This case is restorative obesity surgery at luminal or Rose procedure. Our patient is a 69-year-old woman with class 3 obesity who underwent gastric bypass in 2009. She also has comorbid diabetes and hyperlipidemia. Former biped, she weighed 261 pounds. She lost 61 pounds, but has had recurrent weight gain. Now weighs 244 pounds with a BMI of 40. She underwent diagnostic ECD prior to today, which revealed a 6-centimeter gastric pouch with a 20-centimeter gastrointestinal anastomosis. So we're going to be doing the Rose procedure today, where we use plications to narrow the opening of the gastrointestinal anastomosis.
Oh, thank you so much, Fran, and welcome everyone. So this is a pretty common condition that we see in the bariatric endoscopy clinic, right? The patient had gastric bypass and then had recurrent weight gain 10 years later. Let's pull up on the pressure to 18. So we did an endoscopy earlier, as mentioned. So in contrast to Chris's case, where the pouch was really small, it's 1 centimeter long and very wide outlet, right? For that one. This one is a different anatomy. We're going to section here. Let's just show you the anatomy first. But basically for this patient, you can see that her pouch is quite long. So when you measure, it's about 6 centimeters long. Her outlet was dilated is 20 millimeters. And prior to this, we just did APC to prepare the tissue around the outlet. The setting that we use for APC is fourth APC, flow of 0.8 liters per minute and 70 watts. In contrast to when you use the suturing device, when you do APC for Rose or plication tour, you want the rim of the APC to actually be thinner. So we kind of limit it to only 1 centimeter. And the main reason is because when we place the plication, we're going to go outside of that APC area, as you can see. So we saw this device early on. It's the IOP plication device from USGI. Here, let's go down to 12. And Joni is using insufflator, the laparoscopic insufflator, and Trent is also suctioning to help me pull the tissue in and soften the tissue. Let's go to 18 again, please. All right. And now I grab the tissue, I pass the needle, and now I'm gonna drop the first tissue anchor. Now we're gonna drop the second anchor, and now we're gonna cinch it. And you can see that with only one palpation, you're kind of reducing the size of the outlet already. But the goal for this procedure is that we're also gonna reduce the pouch length as well, that you're gonna see. And now Tracy is gonna load me and give me a new G-pack. And in the meantime, I'm just trying to grab the tissue here. Good. Here, I'm gonna go right here, and the goal is to kind of stay along the circumference. Let's go to 12 again. All right. Yep. And 15 feet. And make sure it's a good bite. So it's kind of like a playground on the insufflator. Make sure it's a good bite. And then move this a little bit. Okay, let's go to 18. And that's the first gauge word. Now we're going to drop the second anchor here and cinch, and you're going to see that the diameter is coming down. You just want to kind of tighten the outlet a little bit so it doesn't become more dilated later on. Looks like we have some room, so I might place one more at the 5 o'clock position around the outlet, and then we might be ready to work on the pouch. Like that might be a good area for one more palpation. And I think we saw this is the third case today with this device, the IOP device. Roman used it earlier for a pulmonary procedure when the jaw here, we call it the G-prop. The one that Roman used earlier is a 33 millimeter. Let's go to 15. It's a 33 millimeter G-prop. The one that we used earlier today to revise ESG, that one is 16. There. Sometimes it happens. It could be a little tight when you do a revision procedure. So if it lets go, you just grab it. Very good. So let's see. Good. Yeah. So for now, I just want to make sure I see it well. Let's go to 18. And you see, for this one, the orientation of the G-prop is very important because you want to reduce the diameter of the outlet. Right? And you may wonder why we're doing this procedure and not ESC4. So we studied to see which device or which procedure would be best to treat weight regain after Roux-en-Y gastric bypass. And what we found was that you can use the anatomy to predict how well they're going to do. For patients who have a long pouch, longer than 5 centimeters, an outlet smaller than 25 millimeters, the plication technique actually gives more weight loss compared to a suturing procedure, and that's why we're offering that. But in contrast, the pouch is really small, like the one that Chris is doing right now, then you need to use the suturing device. So usually we do an EGD, and then you kind of make that decision. You can make the decision real time as well before we go to the So let's go to 15, Jolie. So now I start coming up to the pouch now, guys. And let's go to 14. So I'm just soften the stomach a little bit. That looks quite good. Let's go to 18 again, Jolie. And now same thing, pass the needle through the tissue, drop the first tissue anchor, take out the helix, and then drop the second tissue anchor here. And you're going to see that we're going to reduce the volume of the pouch here by doing that. Yeah, looks like we're getting close. You can see the GE junction on my right. So I think we probably have to move this for like one or two more placations, and that will be it. But the main thing is to make sure you close the outlet pretty nicely, which we did. You can see, doesn't see the opening into the outlet, but trust me, there's an opening there. But this is how you know that you actually close it quite effectively, and then you start moving up to the pouch. Looks like we might have something here, so I might put something here just to reduce the volume a little bit. Here. Go to 14 again, please. And 18. And this device is cleared by the FDA for tissue approximation, so you can use it to perform the procedure, or revision or primary procedure that we saw earlier. Again, light heating it. So you see, like one by one, we just gradually reduce the volume, and we're up pretty high. I might try to squeeze in one more. Looks like there's something screaming at us there in the front. Here we go. So maybe one more, and I think we reduce the volume quite well for her.
Dr. Pishamo, can we just go to Dr. Thompson? He wants to show us the APC and then come back to you. You're on, Dr. Thompson.
Hi there, welcome back. So we did our ESD part of this procedure. You can see all the way around. We've exposed the submucosa and the muscle, which is quite nice, right? And now what we're going to do is we're going to ablate the inner ring of mucosa so that it doesn't get in the way of healing. And we're going to maybe do the outer ring as well. But that's a good view of it right there. That's kind of what we're going for, is that donut. And we have quite high settings on this APC, as you'll see. But so it's a forced APC, about 70 watts. There's a 7 on this system. So we want to destroy this tissue best we can. You don't want any intervening mucosa if we can help it. So we're really going to cook this. Devitalize it completely if you can. Want to not hit the submucosa as much as you can perforate there. We try not to do that. That's pretty good on the inner ring. Got a little more right there. And then we'll hit the outer ring probably. You don't necessarily have to do the outer ring.
Looks pretty.
But it does, yeah, it's pretty when you do that. It might help in healing. You want to see the tissue gets drawn into the beam there because it's such high wattage. Sometimes this will blow us a hole in the side of the catheter because it's so powerful. Almost done. Going all the way around here. And, there's evidence that APC itself can help with weight loss. And it does help with tissue ablation, but it also induces an element of scarring. So APC does have its own use, but normally in an outlet that's not terribly big, it's just kind of confined and super stretchy. And that's pretty much it. So the tissue is well prepared now.
Really nice. Really elegantly done.
Thank you. We're going to start suturing now and go back to side. We'll, yeah.
So yes, Dr. Roland Ecuador, I want to, just for the audience, some comments. What is the advantage to do the TOR versus just PC? What is the difference regarding body mass index lose weight or difference?
Sure. So you get a 12% total weight loss with ESD Tor that's durable, fairly permanent, right? Because you're suturing, you're plicating tissue together to the tissue that's only 5 millimeters away, and there's no mucosa between it. So it's permanent. Whatever you do here is going to be permanent. So we learned that the hard way. We used to have stenosis rates of about 30% until we realized how darn durable this was. So now we've dialed it back. We'll cinch this over a balloon that's 8 millimeters, but it's worth it. And the insurance companies pay nicely for this because they know you get outcomes that are even a little better than surgery. Whereas if you're just going back and doing APC, some people respond, some people don't. You might have to do multiple sessions. This is one session. So I think that it's nice to get a reproducible, durable response and something you can count on. So with that, the tissue is prepared. We're going to go change over to the double channel and put a suturing device down and show you how to do a purse string and size it over a balloon. And you can go back to Sai in the meantime, and we'll see you soon.
Perfect. So now we are going to go back to Dr. Pichamo, please. Boston? Hi, Dr. Tirapino, you can see your slide. Can you show us, please? Yes, now we can see you.
Oh, Oh, hi, welcome back, guys. Looks like we're live. So while you were gone, we placed, I think, 3 more plications in the pouch. I believe we put a total of 7 or 8 plications for her. So we're gonna go back in and take a quick look at the final look, but it looks like the outlet was quite small and the pouch basically was pretty much all reduced. So let's look. But as you can see, it's one way of treating weight regain after gastric bypass. It's quite fast and it works really well for the right patient population that we talked about. Long pouch and outlet was dilated, but less than 25 millimeters. So I'm going to do some cleaning. So we studied this procedure. We looked at about 100 something patients who, that looks really good, that we did the ROSE procedure on. And with this procedure, by combining APC with plication, patients lost 12% of their weight at 1 year after the ROSE procedure. So it works quite effectively if you pick the right analogy. So after the procedure, instruction-wise, so the patient goes home on the same day as the outpatient procedure. They will be on liquid diet for 6 weeks. We also prescribe PPI and Carafate as well for 6 weeks while everything is healed. But you can see her outlet is very small. It's somewhere in there, much smaller than at the beginning. And then basically her pouch is all consumed by these tissue plications. So we really effectively reduce the volume of her pouch by performing a plication tour over the procedure.
That's really nice. It's Vinay Segal from London here. Just a quick question, really elegant demonstration. Do you have a strategy when you're placing your plications? Do you kind of have a roadmap in your head when you go down? And how do you avoid totally obstructing the outlet? I know it's maybe a silly question, but those that don't do this may be worried about inducing a full-on obstruction. What are your thoughts?
Yeah, totally. So for the outlet, my math is that I want to put the orientation of the G-prop parallel to the circumference. So you want to go around it, because if you put it perpendicular to the circumference of the outlet, you actually will end up opening the outlet. But if you go along the circumference, you end up reducing the diameter. So that one is very important. And then when you come up to the pouch, usually you don't want to go perpendicular, especially for the first few plications in the distal pouch. You don't want to go perpendicular to the circumference of the outlet either, because that force can also end up opening the outlet that you just released. And then after that, basically, it's kind of like a diagonal orientation where you get some reduction in width, but at the same time, shortening of the pouch. And then the key thing that I did not mention is that because we're working in such a small space, because this is a revision procedure, it's not a primary procedure, you always want to make sure that you line up your device so that the needle has room to come out. Because if it's too small, and then let's say if you put the G-crop so that the needle comes out at the 12 o'clock position, you might end up going through and through the wall, and then you don't have room to drop the tissue plication. In that case, I would just rotate the device so that the needle comes out at the 11 o'clock position, because you have a little more room. That's enough to drop the tissue plication.
And what is your follow-up with these patients in terms of pharmacotherapy? And is this a day case procedure, or do you keep them in hospital?
Yeah, so it's a day case procedure. So they go home on the same day. They will get PPI and Carafate for 6 weeks. Additionally, all of their medications have to be converted to liquid form or crushable form for 6 weeks while the stomach is healing. And then in terms of follow-up, at our program, we have 11 follow-ups for the first year after the procedure. And these will be a combination of dietitian visits and also MD visit and also PA. So it's a multidisciplinary program that we started.
Thanks. That was really nice. We've done pretty efficient procedure, I would say. Pretty 10 minutes.
Thank you. Thank you. Yeah, very, very fun procedure to perform and very satisfying results when you see them back in clinic.
Very much, Dr. Chamal. Now we are going to go back to Dr. Thompson to finish his case, please.